All right, so for neuropathology week or day, we'll be getting started here. So first case, this is a 73-year-old man who noticed a mass behind his left ear about 6 months ago, and since about 1 month ago has had hearing difficulty and facial droop on the left side. This mass was biopsied at an outside hospital, but aborted due to the bleeding with no significant pathology that was obtained. And the patient denies any past medical history. Tyler, are you there?
Yeah, I am.
All right, perfect. So this is this patient's physical exam. ANO times 3, extraocular wounds were intact, has a House-Brockman 4 left facial weakness, left dysmetria, and full strength throughout.
Okay.
So I'll have you describe the imaging here. Here's the House-Brockman scale for reference. So you want to describe this CAT scan for us?
Sure. So looks to be a hyperdense region in the left temporal, like mid-temporal region, that has some contrast enhancing areas.
So this is a plain CT. There's no contrast here.
Oh, gotcha. Okay, sorry. So it's just mixed densities. And then is this like, this patient have a craniotomy before, or is this invading through the bone?
Yeah, exactly. So it's eroding through the bone windows on the right here. You can see it's kind of eroding through the bone. So
yeah.
You're right, mass in the kind of temporal region here. We're just seeing one slice, but eroding through the bone. So what other imaging would you like?
MRI.
All right, here you go. The T2 on the left, T1 non-contrast in the bottom left, and then the right 3 are with contrast. So why don't you describe what we see here?
Sure. Again, we're seeing this very large left-sided skull base lesion. It looks like extra axial, contrast enhancing, like cystic, like heterogeneously enhancing. It looks like an enhancing cystic component, and then like a non-enhancing component as well, more laterally. It looks like it's attached to the tentorium. It has a supratentorial and infratentorial component at the very least, if not just, I guess what I can't tell is if it's coming from like outside and it's just pushing all of that in, or whether it's originating on the tentorium and going outwards.
Great. Yeah. So you hit the important features. It's extra axial, definitely pushing the brain in, not coming from the brain and going out. Avidly contrast enhancing. And here you can see it's kind of invading the bone and even pushing up into the supratentorial space. Any other imaging you would want, and thinking about maybe, this thing looks pretty gnarly. Any other imaging you might want to consider before considering surgery?
Maybe doing an angio.
Perfect. So here's your angio. And you want to just quickly describe what you see here?
Sure. Okay.
This is an ECA injection, just for.
Okay, thank you. So I apologize. I'm not super familiar with the branch of the ECA, but obviously there's like just diffuse like enhancement of the region in which the lesion is located. With like a feeding, there's definitely a couple of feeding branches, one more superior than one more inferiorly, it looks like.
Yeah, I agree. Yep, definitely like a big tumor blush. You can clearly see where the tumor is the occipital artery, and it seems like most of the feeders are coming there from the occipital artery.
Got it. Okay.
Okay, so that's all the imaging you have. What do you what's on your differential for this lesion?
So some form of like head or neck cancer, like a squamous cell carcinoma. If it's coming, if it's could be a meningioma.
Yeah, so we're thinking about extra-axial. You had said that it may be coming from the dura. I think you mentioned at some point, so a dural base, some sort of large dural-based lesion,
Yeah.
very vascular, seems to be invading the surrounding structures. So I think you hit on meningioma for sure. Hemangiopericytoma or solitary fibrous tumor is up there as well. And then other less likely lesions would be metastasis or lymphoma. But I think you did a good job describing the differential. So what do you want to do for this this lesion?
So surgical resection, or at least biopsy, maybe. But if not, like resection. I guess that I'm not sure if this is really close to sinuses, where it seems like at least you'd be able to debulk the like more lateral portions of it. But
Anything you'd want to do before surgery to
sure,
make
you
surgery
could embolize.
Yeah, perfect. So this patient went for preoperative embolization and then retrosigmoid approach for resection. So we will move to the pathology section. I don't know if Dr. Goltigan.
Here, can you show the pictures, please?
Do you have your slides to share? Or?
I was hoping that you would show the.
Oh, sure. Yeah,
detail.
let me pull up your email 1 second. All right. Can you see those?
Yeah.
Perfect.
So, let's see. So this one has obviously at least a moderate cellularity, and from low power, you can see the telltale staghorn HPC like blood vessels. You see the dilated blood vessels, which are optically clear from this low power, and they have these angulated scalloped shapes. So that's the so-called staghorn blood vessels, typical for the hemangiopericytoma type of the solitary fibrous tumor. Next. And so here you can see the plump cells and a few mitotic figures. There's a mitotic figure close to the blood vessel on the left middle section. Here in this case, the mitotic figure count was more than 5 per 10 consequent high power fields. Therefore, this affects the grade, makes it to grade 3. And then additionally, there were foci of necrosis, as you can see in the center. This light circumscribed area in the center is representing necrosis. So this is a high-grade hemangiopericytoma type solitary fibrous tumor. And this shows the characteristic NAB2 STAT6 fusion. We have an immunohistochemical stain now that shows this as a nuclear labeling. So this STAT6 marker is recent and actually revolutionized the specific diagnosis of the solitary fibrous tumor hemangiopericytoma spectrum, because when it's positive, we have this tumor. There is no discussion. You don't see this STAT6 positivity in meningiomas or other mesenchymal or type tumors, soft tissue type tumors that may mimic hemangiopericytoma. That's it. Thank you.
Perfect. Thanks. Are you guys? Can you see my slides now? Does that work? Hopefully.
We still see the PDF actually.
Oh, really? Okay. 1 second. All right, here we go. As Dr. Koltekin said, the diagnosis here was solitary fibrous tumor, more commonly or previously known as hemangiopericytoma, and there's been a kind of a redescription of it to describe it as solitary fibrous tumor instead of hemangiopericytoma. General age group for this tumor is age 40 to 50, typically in males. There's a 70% recurrence rate, and they can metastasize. The WHO grade can be 1, 2, or 3. In this case, as was mentioned, it was a WHO grade 3. They typically have a poor response to radiation and chemotherapy, and so treatment is predominantly with maximal safe surgical resection. Here are some example images of other locations and lesions. They're thought to originate from the pericytes around the capillaries, and they have that typical fusion that Dr. Koltekin was mentioning, and that distinctive stain that really nails the diagnosis with that STAT6 stain. Highly vascular, as we mentioned, you could see that significant tumor blush in that preoperative angiogram, and oftentimes preoperative embolization can be helpful. High cellularity in these staghorn vascular spaces that was described by Dr. Koltekin. In terms of other markers, they're typically EMA negative, which is the key thing to remember, differentiating it from meningioma, which may be asked on the boards. All right, so we'll go to our next case now. Is Long there? How about Ahmad?
Right, yeah, I'm here.
All right, awesome. So this is a 50-year-old female, history of substance use disorder and breast cancer, who presented with hypernatremia, altered mental status. Also on further questioning, had several months of declining visual acuity. The significant past medical history is that she had breast cancer, had undergone therapy. Here's her physical exam, a little bit confused, ANO times 2. The main findings are really her visual exam. So the ophthalmologist recorded this exam, which is notable for 2200 in the left eye, and the rest you can see here. So we'll move along to the labs. As I mentioned, she was hypernatremic on admission. Urine specific gravity was 1.003. There are her pituitary labs as well. Ahmad, what about these labs kind of jumps out at you? What are you worried about or thinking about?
It's pretty low specific gravity, urine specific gravity, hypernatremic to 150. Kind of.
You were cutting out a little bit there. Can you say that again?
I was just commenting on his hypernatremia of 150 and a low specific urine specific gravity. Kind of makes me think about DI.
Perfect. And the pituitary labs, anything unusual there?
Cortisol is low. Prolactin is within normal. TSH is within normal too. The low cortisol is really sticks out.
Yeah, basically mildly panhypopit. These labs, and then the CT scan showed a small 3 millimeter nodule in the
right.
So that was those are the findings here. So you want to describe this CT for us?
So looking at a CT, it's a non-con axial, sagittal, and coronal CT. There's a isodense mass at the site of the pituitary. Some vasogenic edema also associated with the mass. Concerning for probable pituitary macroadenoma.
What do you think about the location? How does the cella look? Where would you describe this tumor as being located?
It's extending supracellular into the supracellular region.
And does the cella look normal, abnormal?
Looks a little eroded.
Yeah, I
And-
think that's a little bit of
yeah.
erosion, not insanely expanded though, right? So there's you could say there's a cellular lesion with with a supracellular component as well. With the
Got it.
edema and the location of this tumor, anything else you'd be worried about in this patient?
I don't know what happened to my headphone. Sorry. I would be worried about just because there was extension of the edema and probably also like extension to maybe like the temporal region. I'd be worried about seizures.
What if this patient came in? What if they were like sleepy, nodding off when you spoke to them?
I'd worry about like hydrocephalus. I'd be worried about just
Yeah,
like
exactly.
an obstructive kind of
Perfect.
obstructive hydrocephalus picture. Yeah.
Perfect. Okay, so here's your MRI. Why don't you describe what you see here?
Okay, so MRI, I'm looking at, so real illustration of the vasogenic edema kind of extending into bilateral temporal lobes. The contrast MRI shows a diffuse contrast enhancement and maybe also like a capsular component of encasing the mass. Yeah.
Good. Yeah. So there's a cellular and supracellular tumor. There's kind of patchy contrast enhancement, especially around that rim of that capsule, like you described. Perfect. So what would be on your differential for a tumor in this location?
Most likely like a pituitary adenoma. I'd also be worried about like maybe even a cranial pharyngioma. Maybe even like metastatic disease, but less likely sarcoid, maybe even because of the chest CT kind of makes me think about the chest CT makes me think about like either metastatic disease or like maybe a history of like sarcoid or something that could be concerning for like endocrine pathologies or that we're also seeing in the labs.
Great, that's excellent. So pituitary adenoma, meningioma is another tumor that can occur in this location. Metastasis, cranial pharyngioma, you hit on a lot of these. Some people like this mnemonic. I find it more confusing than it is helpful, but in case you want to remember other things, the Satchmo mnemonic can help you remember their cellular, supracellular location. So what is your plan for this patient, Ahmad?
Probably resection. Probably like an endoscopic endonasal approach, or even maybe like I don't know if we could do like a terional or.
Yeah, so I think
that's
a good thought. You want to definitely, the main things here, you definitely want to get a diagnosis. The patient had a lot going on, including metastatic cancer. So initially taken for biopsy via endoscopic and the nasal approach, like you mentioned, and then based on the pathology ended up going for craniotomy for resection. But we'll move forward to the pathology section. So let me pull up those slides. Okay.
So this shows you on the left upper corner the H&E low power. Obviously, there's a cellular lesion in these three different pieces of tissue. And if you go to the other image on the right side, that shows you the modern counterpart of reticulin stain, which is collagen type 4. You can see that on the right side, if you blow it up, there's a acinar preservation on the right side of the picture. Yeah, and this side shows you that the acinar structures that have been preserved on the right side of the picture are lost on the left side of the picture. So you don't see the round acinar architecture on the left side. That means that there is a lesional tissue there. Typically in pituitary adenomas, loss of acinar architecture is a good sign of the presence of pituitary adenoma on the reticulin stain. Okay, that's what this picture shows. You can see the same thing here. Compare with right versus left. On the left, you see a cellular infiltrate. On the right, you see preserved acinar structure. Same thing on the H&E the exact same area. Next. The problem with this is that the pituitary adenoma did not stain with any of the pituitary markers, so it seems to be a null cell adenoma. But when we did breast cancer markers, as you see with the brown reaction product, with the breast cancer marker mammoglobulin and the other GCDFB, you're going to see, you can see a sprinkling of breast cancer cells within the pituitary adenoma. This is gross cystic disease fluid protein, which is also a mammary carcinoma marker. Okay, so the NDKH67 in these regions is higher, much higher than that of a regular pituitary adenoma. So we thought that this represented breast cancer within a pituitary adenoma.
All right, thanks, Dr. Goltikin. My slides.
Which is not unheard of in this institution. We had like adenocarcinomas metastasizing into meningiomas, at least 3 or 4 cases I have seen. And you're probably going to talk about the pituitary region.
Yeah, so kind of stepping back a bit, this is kind of a unique case, but just to think about more broadly, metastases to the cellular and supracellular region, not super common, but about 1% of all brain metastases. The most common tumors to metastasize to this region are breast and lung. This patient happened to have breast cancer. And interestingly, it's typically the posterior pituitary and the stalk that are the most common sites of metastasis. And just as this patient presented with sudden onset diabetes insipidus, as Ahmad was figured out, that actually tends to be very, quite specific for metastases to the cellular and supracellular regions. So something to keep in mind. These patients typically have a high rate of visual symptoms and ophthalmoplegia, and overall prognosis is quite poor. This case again was unique because it was a metastasis, within an adenoma as well. And then to discuss adenomas in addition, so there can be either acidophils, which are the prolactinomas, growth hormone secreting tumors, FSH and LH tumors, and then the basophilic tumors, ACTH and TSH tumors. But about 50% are null, just like in this case. The typical appearance is these monotonous polygonal cells, and Dr. Goltikin explained the pathology very well. So that's, this case is unique in that it was a metastasis within an adenoma. And then just kind of to discuss breast metastases specifically, typically you see glandular and tubular structures. These weren't seen in this case necessarily. It was more the markers that identified it, but just something to keep in mind in case it appears on the boards.
Can you hear me?
Yes.
Dr. Heros. Yes, just a question for you. So it is definite, just take my word for it, that for the volume of these tumors of pituitary adenoma, you wouldn't expect the frequency with which metastases occur in a adenoma, a pituitary adenoma. So why do you think they are more frequent than for the same amount of tissue, say, somewhere in the brain?
I mean,
in other words, this is not uncommon. What I'm telling you is this is not uncommon, and yet it happens with a frequency that is much more than you would expect for the volume of this tumor metastasis within an adenoma of the pituitary specifically. Why do you think that this is not rare?
I mean,
two things that are particular to: number one, the tumor is quite vascular, correct?
Yep.
And number two, and that's why it also occurs in normal pituitary glands with a greater frequency you would expect by the volume of it, is that you have no blood-brain barrier in the pituitary, right? And of course, the tumor is even more broken, but the pituitary itself, you have no blood-brain barrier. So for the tumor for the size of the pituitary, tumors to the pituitary gland, either to the normal pituitary or to an adenoma, are much more likely to occur than for what would you expect for the volume of it. Vascularity and no blood-brain barrier, right? Okay.
Thanks, Dr.
Yeah,
Harris.
completely agreed with Dr. Harris. I also have a personal observation that if you look at autopsies, nobody looks at the pituitary very, systematically, but at breast cancer patients, you can find actually evidence of breast cancer if you systematically look at autopsies of breast cancer patients. So definitely the blood-brain barrier, the absence of that plays a role, I believe. And of course, the vascularity of the region, vascularity of the tumor most certainly contributes. Thank you.
Great, thank you. All right. Let's see. David, are you around?
Hey, yeah.
All right. So this is a 47-year-old with who presented with a week of cognitive decline, word finding difficulty, and right arm spasticity. The patient nearly got into a car crash. They said that they kind of forgot how to tie their hair. They were very disoriented. Past medical history, depression, recently recovered from COVID. Only medication was Zoloft. So this is the patient's exam, alert but very confused, oriented only to himself, mild expressive aphasia, cranial nerves were intact. But on a motor exam, had motor apraxia, but spontaneously moving everything anti-gravity except that right upper extremity, which was flexed, and was mildly hyperreflexic. For the labs and the CSF profile, neurology did a lumbar puncture as part of their workup before they came to us. So here is cervical MRI. Do you want to describe what you see here?
Yeah, so in the cervical MRI, we have a T2 sagittal here. There's a ventral lesion that's causing cord compression level of C4 through 6.
So
It's
the
because
patient
cord compression, guys, don't overread these things. That's not impressive cord compression, right? It touches the cord, but it doesn't really compress it at either level.
Yeah, exactly. So the patient has kind of cervical degenerative disease, some disc bulges, but really not any significant cord compression, and certainly not enough to explain the exam. So what other imaging would you like?
So I want an MRI brain with and without.
Perfect. Okay, so this is MRI. And here are some other sequences for you. You want to describe what you see here?
Yeah, so there's multiple enhancing diffusion restricting lesions bilaterally, internally in this setting like this. I would suspect something like diffuse metastatic disease.
You said diffusion restricting?
Yeah, restricting. Yeah. So the other thing could be embolic infarcts.
So what do you see on the DWI and the ADC?
So the DWI is diffusion restricting bilaterally. It's also bright on ADC.
So on ADC, what would you expect if it's an infarct? Would you expect it to be bright or dark?
No, it'd be dark on ADC.
Right. So what do you think if it's bright on ADC? What do you think about that? So what's important about the ADC is it kind of differentiates between whether it's an infarct versus like true diffusion restriction versus what we call like T2 shine through. So in this case, that's probably what it is. A T2 shine through is bright on T2 and probably not truly diffusion restricting. So what's on your differential? You mentioned some things. You want to broaden that a little bit?
Yeah, so in this case, I would suspect so metastatic disease. Can think of it primary CNS lesions, and in this situation, things to consider is if you have like embolic phenomenon, infection that the CSF didn't resemble it. CSF didn't resemble an infectious profile.
Yeah, so kind of a broad differential for this. There are some general categories, and then we can break it up a little bit more. There's, an inflammatory and demyelinating pathologies that can show up, can show this kind of diffuse flare changes. Neoplastic, as you mentioned, metastasis, lymphoma, infectious pathologies. Like you said, CSF was drawn and not concerning for this. And then, less likely to be ischemic or vasculitic changes. So broad differential. What would be your plan for this lesion or these lesions?
I think something like this, I do biopsy, looking at series, if they still have CSF sample, you can do some like flow cytometry as well for their analysis. But you do a biopsy of a more surgically accessible lesion.
Yeah, I agree. Definitely need tissue for diagnosis. If nothing else is yielded a diagnosis. So the patient went for a stereotactic needle biopsy.
Did you do a metastatic workup? Did you look at the rest of the chest and abdomen and so forth beforehand?
Yeah, all that is negative. Yeah.
Okay.
The other important part, Silva, is like her history of the COVID infection, previously. So you want to discuss differentials associated with that before the biopsy?
Yeah, I mean, a lot of these, these inflammatory lesions, pathologies often follow a viral infection. I'll discuss that in depth after the pathology section. But yeah, exactly. Having a recent viral infection raises suspicion for a post-viral, post-infectious pathology, autoimmune situation. That's why, inflammatory and demyelinating pathologies are at the top of the differential here. All right, so. All right.
So this is a sort of a medium power H&E stain, and you can see, a relatively cellular lesion. And one of the caveats in surgical pathology is, when you see this on frozen section, you could think of a glioma if you haven't done a touch prep and see what actually this is, which is a bunch of macrophages. But it's a difficult diagnosis on frozen section. On permanence, of course, we're more, there is more resolution, and you can see in the center, there's a blood vessel with perivascular lymphocytes as well. Let's see the next slide. You'll see what I mean. Yeah, so here you see a combination of histiocytes and actually glial cells, reactive scoliosis. Next. And there are these weird looking 3 big large cells in the center. They are forming kind of a circle. Yeah, these are funny looking macrophage mitoses, not an indicator of malignancy. We see them in demyelinating lesions all the time. Next. If you didn't believe me, if you do a histiocyte marker, such as a CD68, wall-to-wall positivity. On the left side, you see the lower power picture. On the right side, you see, what you would see if you turn to the high power lens in the microscope. It's like totally riddled with macrophages or histiocytes. Next. So it's a histiocyte-rich lesion. So next in neuropathology, what we do is we do a myelin stain. In this case, it's Luxol Fast Blue, LFB. And normally, the LFB stain in normal white matter would be, really, really dark blue all over. And here, there's this very pale hue, which means the myelin is lost. And if you look at the contents of the histiocytes, there is this stippled appearance in individual cell cytoplasm, which means they are digesting the myelin debris. So there seems to be some active demyelination here, which will be corroborated by the next slide, which means we do a neurofilament stain and we prove that axons are relatively preserved. Okay, so if the myelin is gone and the axons are preserved, that means there is a primary demyelination. If both axons and myelin are destroyed, that means this is necrosis. Could be infarct, could be a toxic, reason or otherwise. But in this case, it looks like that there is a preservation of axons and loss of myelin. So this should be a demyelinating process. Next. And there is gliofibrillary acidic protein positivity. So there is the inevitable reactive scoliosis, which makes things a little difficult for, again, in case the surgeon sent it for a frozen section, it may be a difficulty that I'm just demonstrating here. Next. Is there any other? Yeah. So there's also, I talked about blood vessels and perivascular lymphocytes. There is some sprinkling of mature T cells here in the parenchyma and in the perivascular areas. So, and this can be seen in various demyelinating conditions. Of course, it can also be seen as encephalomyelitis, if that were the case, or even paraneoplastic disease. So in and of itself, it's not specific, but it is a part of the demyelinating process. That's it. So the differential, you're going to talk about the differential, I'm sure, but depending on the age group you and the history of the patient, you can prioritize what is your top differentials. In a 30-year-old woman, I would think of multiple sclerosis. In a 75-year-old person with lymphoma, I would prefer PML, the upshot. And of course, if it's an acute phase clinical syndrome, acute demyelinating encephalomyelitis and other types of acute demyelinating single phase monophasic demyelinating disorders would be in the differential. So go ahead.
Right.
Just before you go to the next case, just to make the point that the initial slide of the pathology, the frozen section, emphasizes, that Dr. Gutelkin said, these are macrophages, but on the frozen section, they can be confused with neoplastic cells, particularly with a neuropathologist less experienced than Dr. Gutelkin. So I had a case, the cases that sometimes MS, the myelinating disease, presents as a tumorogenic MS in the frontal lobe, big lesion, looked like a tumor on frozen section with all these macrophages. We thought, well, this is a malignancy. So I did a resection, and this turned out to be tumorogenic MS, or whatever different ways of calling. What is the name, other names used, but a monophasic one mass of acute demyelination, sometimes recurs, sometimes goes on to multiple sclerosis. But the problem is confusing these macrophages on the frozen section with neoplastic cells that can lead you to go ahead with a resection that is obviously not indicated. In fact, in my case, that I remember, was even worse, because I even used that the wafers, I forgot the name, the wafers that we used to use 20 years ago, thinking that this was a malignant tumor, and then I had to go back and take all that out. So that is a mistake that can be made because of the shape of the, you have this fairly crazy looking, neoplastic looking macrophages that can be confused with neoplastic cells.
Great, thanks, Dr. Harris. So the diagnosis in this case was acute disseminated encephalomyelitis. So this is basically an inflammatory reaction of the brain and spinal cord. And given this patient's recent COVID recovery, that's why this would help arrive at this diagnosis. It's more common in children, but can occur in adults, and is typically has multifocal neurologic deficits that are rapidly progressive. Interestingly, it typically presents with weakness in one or sometimes more extremities, just like this patient had that right upper extremity weakness. Interestingly, it also typically presents with pseudobulbar palsy. The appearance of it, Dr. Gutelkin explained, very well. You get this demyelination with the preservation of the the axons themselves. And like I said, often follows a viral illness, 50 to 75% of cases, and the time gap can vary. This patient had COVID about a month prior. The thought is that the body is producing cross reaction to the myelin antigens that are then destructive of the myelin. And it's been associated with many viruses, including coronavirus. So again, that's why COVID was a tip-off here. In terms of imaging, typically multiple, oftentimes in both hemispheres, multiple deep and subcortical T2 hyperintense lesions, as we're seeing in this patient, and often heterogeneous, sometimes enhancing, sometimes not enhancing. They can present with restricted diffusion in the acute setting within the week, but then the ADC will normalize over time, which was seen in this patient as well. And often in a year to 2 years, the MRI abnormalities can resolve. CSF can be normal, as it was in this patient, but may show a mild protein elevation or a lymphocytic pleocytosis. And then importantly, to differentiate this from MS, although the history is obviously incredibly important. So ADM is typically more likely to follow a viral illness, often presents with nuchal rigidity or fever, also more likely to cause encephalopathy like this patient had, and more widespread neurologic dysfunction as opposed to a focal neurologic deficit that may be more common in a patient presenting with MS, also more likely to cause ataxia. And typically the lesions, as I said, are often bilateral and larger on MRI. So altogether, the history and the imaging can be suggestive of this over MS. Treatment, high-dose steroids, IVIG, and plasma exchange. 4 to 12% mortality, usually monophasic, but in about a quarter of cases, there can be a relapse. So, these are patients that often go through neurology, but sometimes come to us for biopsy, and it's important to help, to be familiar with the differential and how to work it up.
Michael,
So moving
how
along.
is this patient
Yep.
doing? Do you know?
Not well. She's like in a discharge to an LTAC, extremely moribund from her encephalopathy. And they tried like several rounds of Plex and IVIG with her, and it has not worked. So they're actually writing this up as like a case report because it's not like typical like ADEM per se, and it's been refractory. And they had another case, I think, with Dr. Levy as well, that they biopsied the spinal cord and they had another kind of necrotizing myelitis associated with a COVID infection. So
I think that case may have been published already, the one that you referred to. Did they do plasma pheresis in this case?
they did.
Okay.
All right. So our last case of this morning, Adam, are you there?
Yep, I'm here.
All right. So this is a 42-year-old gentleman with a history of DVTs on warfarin, presenting with low back pain, knee pain, saw his orthopedist for the knee pain, difficulty walking related to the knee and the back pain. He describes the pain as worse when lying down, improved when he sits, denies any urinary or bowel issues. Past medical history, as I mentioned, DVTs on warfarin, and some mild hypertension. So what kind of imaging would you want to start with for this patient?
So we can start with the CTs first. I would start with the thoracic and lumbar spine.
So let me give you the physical exam first. Alert-oriented, full strength in the upper extremities. In the right lower extremity, he has 4- in the TA and 3 in the EHL. The left leg is full strength. Right lower extremity has kind of decreased sensation to light touch in a non-specific distribution, and 2 beats of clonus in the right foot. So I think your imaging request is appropriate. I'm going to give you
before you
MRI.
even look at the image, just from that history, there's something very specific to one of the interns. I know the mid-level residents know that, but what about that 2-line history is very suggestive of a type of problem with the spine. What is interesting about that history? No, wait a minute. You put this, maybe the next. Yes, right. Ask David. Most patients that you see have degenerative disease, right? have just degenerative disease, spondylosis, and so forth, the pain is usually worse when? Hello?
Adam, you wanna?
Yeah,
Alan?
so the pain is worse when you have a lordosis, and then once you start the patient's in kyphosis position, the pain is improved. So when they're like standing,
Look, this pain is worse when laying down. What is that common on the patients that you see day in and day out with degenerative disease of the spine?
no,
No, the pain is worse on exercise, on walking, and right?
yeah.
So this is something unusual. So whenever you have this history, you think of what? Of tumor.
So you think of tumor in the bones of the vertebral spine, something that's what
Right.
I'm
Right.
thinking about
So
right now.
pay attention to the history. The history is very important. In these 2 lines already gives you a clue of what you're going to be looking for. Okay, go ahead.
Perfect. Thanks, Dr. Harris. All right, so that's the exam. We're going straight to MRI. Adam, you want to describe the lumbar MRI for us?
Yeah, so I'm looking here at the MRI of the lumbar spine, T2 on the left and T1 on the right. I don't see anything significantly. Like the canal appears to be clear, nothing there.
I agree with you.
Good.
Yeah,
Move on.
Looks like a pretty nice spine.
yeah,
So we're gonna move up to the thoracic spine. You want to tell us what you see here?
yeah, sure. So on the T2, you see probably an intradural intramedullary tumor there at the level, I'm assuming this is T12. Is that T12?
Yeah, exactly.
Yeah, that's it has I think it's so on T1 with contrast with GAD, it's not enhancing. It's there's like minimal shade of enhancement that extends beyond the tumor itself, up to T11.
Good. So there's a non-enhancing or maybe mildly enhancing lesion with a cystic component there, and it's right at the conus, right?
Yeah.
So what's on your differential for a tumor in this location? You already described it as an intradural intermedullary tumor, which is good. So what would the differential for that be?
Yeah. So most common intradural intermedullary would be like you would think about like astrocytomas. You would think about hemangioblastomas. You would think about Mets.
Especially at the
There is a
conus.
very important one you haven't mentioned.
At the conus.
The most common.
Most common in the conus, like phylum terminale, like no, sorry, like ependymomas.
All right, got it. Okay.
Good. So I think you hit on all the big ones. So ependymoma, astrocytoma, and hemangioblastoma at the top. So what would your plan be? Here's your imaging again.
So I think your plan is trying to get a resection. So you would do a laminectomy and posterior laminectomy and a resection of the tumor, like try to get hopefully a gross total. I would go up to that, like mildly enhancing lesion, take it out as well. So I'd go T11, up to T11. Try to get like a gross total resection of that lesion as well.
Perfect. All right. So we'll move to the pathology.
Okay, so this is an interesting and unusual case. I remember seeing the frozen on it. You know, as usual, surgical team was wondering about ependymoma versus astrocytoma. We couldn't find anything that looks like an ependymal lesion. So we said it looks like a low-grade-ish astrocytic neoplasm on frozen. And here is the paraffin. You see a relatively vascular rich lesion here. It has some cellularity, abnormal cellularity, but it does not seem to have any rosette formation. Next. So you can see here basically a glial proliferation. That's number one. Number two, you see some hyalinized blood vessel walls. And interestingly, on the right side, mostly actually on the left lower also, you see a lot of Rosenthal fibers. So it's a deceptive situation, because when you see Rosenthal fibers within a tumor, you think about pilocytic astrocytoma, PXA, and ganglioglioma, DNET, and other things. So mostly grade 1 tumors. And next slide. So there are also other parts of the tumor which look, that there's a halo around the individual tumor cells. These are not all macrophages or oligodendroglial cells. But there is a couple of macrophages here and there on the left side of the left picture at the top, of unknown significance. Next. It's just that it's not a hemangioblastoma, GFAP is diffusely positive, OLIC2 is positive. These prove that this is a glial lesion, okay? Especially OLIC2 is nuclear marker and easier to interpret than the GFAP, which seems to be a diffuse presence here. Next one is ATRX. ATRX is lost here in tumor cells. ATRX, if to remind you, the loss of this marker is associated with the diffuse astrocytoma. True molecularly proven diffuse astrocytomas have ATRX loss. Pilocytic astrocytomas do not have that. Oligos do not have that. There are some exceptions, as in this case. The Ki67 index is low, pretty low. It's like maybe 2% or something like that. The problem is, go ahead and move on to the next. There is this marker H3K27M, which is a mutation-specific immunohistochemical tool that we use to identify the mutations in this histone acetylation element. Unfortunately, this is widespread positive, indicating mutation. So now the diagnosis completely changes. It's very interesting, because this explains why, in the last 30 years, I have seen sometimes things that look like pilocytic astrocytoma in the spinal cord, and they behave badly, as opposed to what the pathology says. So this marker immediately elevates this tumor to a grade 4 behavior. So now we call these diffuse midline gliomas H3K27M mutant. So, and it can occur in midline, in the thalamus, in the brainstem, in the spinal cord. You'll probably talk about these things. So that's where the buck stops, When you see this, your diagnosis changes despite what the morphology shows. Okay, thank you.
I was going to say that, in keeping with that, he as many of our patients, at least 10% presented with COVID during his workup, and we had to delay his surgery by 3 or 4 weeks until he was COVID negative. And during those 3 or 4 weeks, he got quite a bit worse in his right leg. He already had some right leg weakness, but in that 4 weeks, it got worse. And that's not typical for a low-grade tumor to get worse over such a short time period. He was presented before because he had the DVT and the PE and the resuscitation. So Christy presented him last week as a resuscitation success. So he's now in rehab, and we referred him to neuro-onc to present him at rounds to figure out what's the next step. Is it radiation? Is it chemotherapy? Is it what? But it sounds like he's not going to do great based on the molecular markers, even though the Ki index is very low.
Yeah, exactly.
Just to follow up, we actually discussed this very topic a couple of weeks ago, morning conference, that how differently pilocytic astrocytomas that look histologically identical, how differently they behave if they are in some locations like the optic nerve or the cerebellum. They behave in a very benign manner, whereas the more central midline pilocytic astrocytoma, say of the optic tract, for example, that involve the hypothalamus and so forth, behave very badly as malignant tumors practically. And that the explanation may be that those tumors in the midline have this mutation abnormality that I knew nothing about, but that must be the explanation. That it's really a different tumor depending on location. And I suspect that you won't find this mutation marker on the pilocytic astrocytomas of the cerebellum or of the optic nerve, for example, that behave very indolently.
Yeah, exactly. So the H3K27 mutation here confers to the grade 4. So we're more familiar with the pediatric form of diffuse midline glioma, but in the spine it's much more rare. The pathology, Dr. Gauthier explained well, has a low-grade appearance on histology, low Ki67, but the behavior of the tumor is that of a high-grade lesion. In this case, again, the molecular features are the most important, and it has an incredibly aggressive behavior. In kids, the prognosis is 9 to 15 months survival. In adults is more variable, but tends to be a little bit better. And the recent WHO classification, they've even broadened beyond just the H3K27 mutation, but other methylation changes and genetic alterations here can confer an equally poor prognosis for these patients. So they're now considered H3K27 altered as their terminology. Management, radiation, chemotherapy. There's some case reports of use of Avastin with maybe some improved outcomes, but again, an abysmal prognosis for these patients, even though adults do tend to do slightly better than children. And the spinal diffuse midline glioma does seem to do slightly better than the intracranial form. So that's all I got.
Thank you, Michael.
Thank you. So we have a guest speaker for the second hour, Dr. Deborah Heroes, who has a long-standing, very close working relationship with our department. She's part of the neurology department and an integral part of the cancer center with a long experience in neuro-oncology. And we're very happy to have her join us for the first time in a while in doing a grand rounds for us, and she's going to give us an update on brain metastases. Dr. Heroes.
Great, thank you, Howard. Let's see, can I automatically share my screen? Okay, as Howard mentioned, today I'd like to talk about an update on the management of brain metastases, and I organized this mainly as a presentation to the residents just to discuss the interdisciplinary approach to metastatic brain tumors and where we're at today, and emphasize how important the neurosurgeon is in the management of these tumors. And just to put this in perspective, and you can, the slides are okay? I can't see it, yeah. So the slides are okay?
Yes.
Okay, great. Okay. So just to put this into perspective, every year, the case number of brain metastasis is increasing, and there are over 200,000 cases per year. And that's 10 times the incidence of primary brain tumors. Up to 30% of patients with cancer develop metastatic brain tumors at some time in the course of their disease. And I think it's important to talk about this topic now because we are seeing increasing treatment options, and oftentimes the treatment options, one is dependent on the other. We also are seeing improved survival of our cancer patients, and improved responses and survival from the CNS disease. So now the majority of patients with brain metastasis do not die from their CNS disease. And it wasn't too many years ago that if the patient developed brain metastasis, it was palliative radiation therapy and an automatic hospice. And now this has changed such that the management of the brain metastasis is no longer a one-time approach, but ongoing throughout the course of the patient's disease. And we have to continue to individualize the treatment decisions. And in this, the neurosurgeon plays a major role in the management of these tumors and often throughout, again, the course of their illness. So looking at the spectrum, neurosurgeons are involved in some and not all brain metastasis. For example, this is a woman with breast cancer, ataxia, early hydrocephalus, and a single large posterior fossa metastasis. This is a patient with lung cancer with a large cystic metastasis in the motor strip with focal motor seizures and leg weakness. This is a patient that presented with known melanoma and years later presented with somnolence and was found to have this miliary pattern of metastatic melanoma. And here's a patient that presented with known lung cancer, came in with headache, and the thoracic MRI on the left actually shows leptomeningeal disease. So all of these patients would be treated quite differently. This is a patient who presented with seizures, and the right hand MRI would suggest that there are multiple small metastases. But if you look at the location of the metastasis, they're actually located in the base of the sulci. And the sagittal MRI tells you that this is an extreme form of leptomeningeal disease. And those metastases are actually what we call bulky disease from leptomeningeal disease. And I think the reason this is important is to identify this because otherwise the patient may receive SRS to all those small lesions, and the real problem is involvement of the leptomeninges throughout the neuroaxis, and that would make a difference with our treatment decisions. So who is at risk for developing metastatic brain tumors? Any tumor can metastasize to the CNS. However, lung, breast, and melanoma account for the majority. And keep in mind that lung cancer is 30 to 60% of the brain metastasis of known cancer, but in up to 30% in some series, patients present with neurologic symptoms as the first manifestation of their malignancy without a cancer diagnosis. And within this group, over half of those patients will also prove to have lung primary. So I wanted to talk about the behavior then of the three major malignancies that contribute to brain metastasis. The more we understand the behavior of the specific type of cancer, the better we can be at selecting appropriate treatment strategies for these patients. So as I mentioned, lung cancer is the most common primary tumor to metastasize to brain. And between 18 and 65% of lung cancer patients develop brain metastasis. And that risk, there's such a high range because that risk of developing CNS disease is dependent upon the original tumor cell type of the lung cancer. So we know that small cell lung cancer is the most at risk for developing CNS disease. 40% clinically and up to 50% or even 60% at the time of autopsy have extensive CNS disease. 10% at the time of diagnosis. This disease has a high risk for leptomeningeal spread, and oftentimes they're multiple and miliary, like that melanoma MRI that I showed you. And because of this, small cell doesn't tend to be a neurosurgical CNS disease. Sometimes for biopsy, for diagnosis, but for management, probably not a major role. Non-small cell lung cancer is also very common. This includes what we know of as adenocarcinoma, 30 to 40%, and squamous cell is fairly infrequent. Oftentimes, if we see a metastatic lesion in the CNS from squamous cell, in reviewing the primary pathology, it was actually a mixed non-squamous and squamous cell tumor. So squamous cell is infrequent enough that I think if the patient appears to develop neurologic symptoms with squamous cell, even think of a different diagnosis than metastatic squamous cell. The time interval between the diagnosis and the CNS disease is relatively short, 2 to 9 months. And 30% of non-small cell lung cancer actually develops within the first month of disease. And oftentimes, as I mentioned, it may be the first presentation of their malignancy in what we call a synchronous presentation. Breast cancer, the second most common malignancy to develop CNS disease, is the second leading cause of cancer deaths and accounts for up to 20% of cancer deaths in women. Clinically, we see CNS disease in up to 15% of patients, but higher at autopsy with leptomeningeal disease found at autopsy. In this disease, CNS involvement usually occurs in the setting of widespread systemic disease, liver, bone, lung, and so on. And that is important because their systemic disease and the management of their systemic disease also needs to be taken into consideration when we're planning treatment strategy then for their CNS disease. And the time interval between the initial diagnosis and the development of brain metastasis is longer than lung cancer. It's usually later, can be earlier for HER2 positive patients, triple negative patients, or younger women, but usually it's a later complication of breast cancer. Unfortunately, we're probably seeing an increased incidence of CNS involvement with better systemic control. And we tend to still think of the CNS as a sanctuary site protected from systemic therapy because of the blood-brain barrier. The other information about or the behavior pattern of breast cancer to understand is that it has a high propensity for other tissues, and those involvement of other metastatic complications of breast cancer then can involve tissue that may cause neurologic symptoms. So it's important understanding the disease and being able to localize the neurologic symptoms. For example, bone is a very common site. So they get base of skull, bony disease with cranial neuropathies. Breast cancer tends to spread to the dura. Leptomeninges, as I mentioned, with involvement of the CSF and the brain parenchyma. And oftentimes breast cancer patients will have multiple compartments that are causing various neurologic symptoms. Women at highest risk include patients with a high histologic tumor grade, a larger tumor, and their ER/PR/HER2 status is particularly important with the high-risk patients, triple negative, as I mentioned, and HER2 positive, oftentimes both seen in younger ages. And if there's a short interval between the initial diagnosis and the time of relapse, they have a higher incidence, and also the site of recurrence. So women with visceral, lung, and liver metastasis have a higher risk. As I mentioned, in premenopausal disease, the tumor does tend to be more aggressive, more likely to develop CNS involvement, and the major driver of this is the HER2 positive mutation. And HER2 positive patients do have earlier CNS involvement and are higher risk for leptomeningeal disease. And I think that what is becoming better understood is that even patients who begin with HER2 negative primary tumors, up to 20% of those patients who develop CNS disease have acquired HER2 alterations, and that HER2 mutation appears to be a major driver for developing CNS disease. And we'll talk a little bit about the genomic evolution of tumors. And I think this is, we're starting to understand why some of the CNS disease of breast cancer patients was previously unresponsive to our treatment. And it probably has to do with this acquired mutations that the cancer patients develop. So here's a spectrum of patients with breast cancer. This is a woman who developed dural involvement. She declined radiation for a very long time. And from this dural involvement, she's at risk for brain involvement and leptomeningeal disease. So unfortunately, because she declined radiation, we have the opportunity to see the complication, and you can see the cortical invasion, seizure activity occurred, and she developed leptomeningeal disease. This is a patient that developed dural disease and has a malignant subdural effusion. Keep this in mind when you see a patient with an atypical subdural effusion. Breast and prostate tend to cause this. It's infrequent, but it does occur. So keep that in mind in your differential diagnosis. For some reason, the breast cancer patients have a propensity to develop posterior fossa disease. And this is a patient that developed a brainstem metastasis as well as leptomeningeal disease. And I think you can see the leptomeningeal enhancement. And this is the bulky disease of the posterior fossa. And probably the posterior fossa is involved sometimes with local leptomeningeal disease, because oftentimes women develop dural metastasis in the posterior fossa, which leads also to leptomeningeal involvement. And oftentimes the LP is negative, but we can see the folia enhancing and the leptomeningeal component to the disease. And this is a patient presenting with headache with known breast cancer. Sometimes the leptomeningeal enhancement can be rather subtle, but the best place to see it is on the sagittal section, looking at the folia and around the brainstem. And this patient actually has early leptomeningeal disease. Not all dural lesions are metastatic breast cancer in a breast cancer patient. This is a meningioma, and there does seem to be an increased incidence between having breast cancer and meningiomas, so keep this in mind. I think it also reminds us that many of you as neurosurgeons will be asked to see incidental meningiomas. And in many of them, of course, we can observe them, but it's also important to take a history and caution them that they should not take estrogen and progesterone hormone replacement therapy because of the potential for exacerbating the meningioma growth. About half of these have estrogen receptors and progesterone receptors, and also to remind them to have their mammograms. So in management of the patients, that can be very helpful to counseling the patient. Melanoma, we are seeing an increased incidence. The prognosis depends on the initial stage overall for melanoma, but melanoma has a high affinity for the CNS. And in patients who have metastatic melanoma, up to 60% develop brain metastasis, even higher at autopsy. And again, leptomeningeal disease is fairly common with melanoma. The time interval between the initial diagnosis of the melanoma and CNS involvement is quite a wide range. And this just underscores, I think, the inability to predict melanoma, anywhere from 2.5 years up to 27 years, case in the literature. In general, once the patient with melanoma develops CNS disease, it does carry a poor prognosis. However, I put this in red because it may be changing with some of the newer therapies. Our BRAF inhibitors for BRAF mutant melanoma and our immunotherapy certainly has improved the overall outcome. But this is one tumor where the patient still tends to succumb because of their CNS disease. And keep in mind that this is one cause of hemorrhagic metastasis, so an atypical presentation of a hemorrhage. Think of an underlying melanoma. So we're all familiar with the decisions in determining our treatment strategies. And those decisions depend upon the CNS tumors, the systemic disease, and the overall condition of the patient. So for CNS tumor characteristics, we take into consideration, of course, number, whether it's a single met versus what's called oligometastasis, usually up to 4, and then multiple metastasis. The size of the lesion, whether it's causing symptoms, the location, if it's surgically accessible or not, the pathology of the tumor and the primary disease can be important in making a decision because, for example, renal cell carcinoma oftentimes is a single metastasis, is relatively radio-resistant, and if in a surgical location may be more amenable to resection than, say, again, small cell lung cancer. Oftentimes, prior treatments may limit our options because there may be prior radiation, prior SRS, for example, increases the risk of radiation necrosis if we're going to plan on whole brain radiation therapy and so on. The systemic disease status is a big factor, and that's why in tumor board, we're constantly asking, the status of the systemic disease, the ongoing treatment for systemic disease, because that can influence our neurologic management. And of course, the patient characteristics, age, neurologic performance, and other medical comorbidities. So all the subspecialties are involved in providing treatment options for metastatic brain tumors. And all of the subspecialties are identifying new treatments, and that's why it's so important for a multidisciplinary tumor board to exist and to work in a multidisciplinary way in developing treatment options. And equally important, of course, is management of the patient's symptoms from their tumors, as well as management and identification of the treatment-related symptoms. So neurosurgery, this is, of course, a slide that you're all familiar with, but the role of a neurosurgeon to biopsy the lesion. And our purpose for biopsying now actually has increased, and not just to identify recurrent disease or establish a new diagnosis, but now biopsying becomes more important in identifying the genetic profile of the metastatic tumors, because as I'm going to mention in talking about this genomic evolution of cancer, the brain tumor metastasis may be different than the primary tumor, enough that there may be new treatment options for the brain mets that otherwise would not be identified from just relying on the pathology of the initial biopsy. Resection, there's increased interest in considering stereotactic radiosurgery prior to surgical resection, with the idea of possibly decreasing the risk for local seeding at the time of resection, the development of possibly leptomeningeal disease or even radiation necrosis. And there are now a few studies around the country looking into using SRS prior to surgical resection. Surgical techniques certainly have improved the ability to perform a safe resection. And the use of the laser interstitial thermal therapy or the laser ablation is really an amazing technique for treating these patients. It's helpful for ablating the tumor or radiation necrosis, and that makes it particularly an effective treatment option for patients, because oftentimes we don't know, without doing a biopsy, whether or not it's recurrent tumor or radiation necrosis, or a high probability of being a combination. Simultaneous biopsy can be performed. We'd like to see a larger biopsy to be able to perform more testing on the specimen, and hopefully as the neurosurgeons become more familiar with the procedure, that will be possible. And as a neuro-oncologist, I just stress the importance that now that we are causing lesional, ablative, destructive lesions in places where neurosurgeons did not operate before, that we really keep in mind the risk of developing disconnection syndromes. We're now ablating large tumors in the corpus callosum, the splenium, and deep white matter structures, and kind of just flash those images in your mind when you're deciding whether or not to perform an ablation procedure. And I think it's very important that we start to monitor the outcome of these ablative procedures by doing neuropsychometric testing. For treatment options, the radiation therapy has also been very important. Whole brain radiation used to be the palliative general approach. Now we try to avoid it, or at least delay it until a very late stage, because of the sequela of whole brain radiation therapy. To try to avoid the toxicity, the radiation oncologists are using hippocampal avoidance whole brain radiation therapy with memantine to try to reduce the cognitive impairment. Stereotactic radiosurgery is a very important tool in treating these patients. The number of tumors that can be treated certainly has increased over time. And again, the role of adding SRS prior to surgical resection, I think, is an interesting concept, and the value of that needs to be determined. The limitation of SRS is not only the development of radiation necrosis, but the fact that it provides good local control, but doesn't prevent the development of distant disease. And yet combining SRS and whole brain just has excessive toxicity as a general treatment strategy. Immunotherapy combined with SRS is an interesting concept, and it may be that there's synergy between the two treatment modalities, in that SRS may actually trigger the upregulation of PD-L1 and then make the tumor more susceptible or sensitive to immunotherapy. So there are now different clinical trials looking into combining the two with having SRS prior to immunotherapy. And we do know that this combination also increases the risk of pseudoprogression and radiation necrosis, so that looking at the timing between the two therapies, as well as the potential of adjusting the dose of SRS to minimize the radiation injury, are being considered. But it's an interesting concept, and that combination we may see more in the future. It's also important as a neurosurgeon to be aware of that, because if we expect to see MR changes after we're combining these treatments, then we become more familiar with the expected behavior and possibly reduce some of the craniotomies and invasive procedures for these patients. And then the radiation oncologists are also now readdressing the role of complete neuroaxis radiation therapy for patients with leptomeningeal disease. In general, for adults, they tolerate very poorly complete neuroaxis radiation therapy, but now the radiation oncologists with the use of proton therapy are performing this on certain patients with leptomeningeal disease. And to be honest, they are tolerating it. And what role this will play in the overall management of leptomeningeal disease, I think needs to be determined. So just to remind us of the sequelae of whole brain radiation therapy, it produces diffuse atrophy over time, as well as a leukoencephalopathy with compensatory ventriculomegaly. This is not hydrocephalus that responds to shunting. Clinically, the patient does look like an NPH syndrome with memory and cognitive impairment, gait disturbance, incontinence, and unfortunately does not respond to shunting. So again, keep that in mind when we see our patients with prior whole brain radiation therapy, and especially patients who have received intrathecal chemotherapy or high-dose methotrexate or other neurotoxic chemotherapies. It's also a reminder that some of these patients can become neurologically impaired because of the effect of radiation on the hypothalamus and the pituitary. So on a yearly basis, in patients who have been radiated, we will do a hormonal profile to look for endocrine insufficiencies. And this is just showing the mapping of the hippocampal avoidance whole brain radiation therapy as an attempt to decrease the cognitive impairment that these patients experience. We're all familiar with radiation necrosis from SRS, about a 10 to 20% risk. And this gives me an opportunity just to mention the management of our radiation necrosis in these patients. For asymptomatic patients, sometimes observation is appropriate. Short-term dexamethasone may be beneficial, but the limitation of the dexamethasone is the potential long-term side effects if long-term therapy is necessary. Bevacizumab can be very effective. It does pose some risks, and if any kind of neurosurgical procedure is considered to occur in the future, we have to be very mindful of wound healing impairment and the development of CSF leaks. Surgical resection, it can be very beneficial, but again, it's a procedure where the tissue is removed, whereas in my opinion, the bevacizumab offers an opportunity to restore some of that function. The laser ablation has been very effective, and I'll show some examples of these different treatments later on. But again, we just have to be very mindful of neurologic higher cognitive executive dysfunction from disconnection. And another treatment modality that has been used is hyperbaric oxygen therapy when there are contraindications to all of the above. And again, that can be very effective. The risk of doing hyperbaric oxygen therapy is seizure activity in the chamber. And so oftentimes we will pre-medicate the patients and make sure they're on an anticonvulsant before hyperbaric oxygen. The systemic therapy, I think, has been an area where there's an increased interest, and chemotherapy still plays a role, but probably now in combination with other therapies. Immunotherapy has become very important, especially for patients with melanoma and lung cancer. May become more important if we can increase the sensitivity to immune therapy by stereotactic radiosurgery as a primer. And targeted therapy, I think, has really brought about many new interesting treatments for metastatic brain tumors. And targeted therapy refers to targeting various genomic DNA mutations of the cancer cell. And there's now a large group and rapidly growing exponentially option of small molecule inhibitors that cross the blood-brain barrier and can be very effective, as well as a group of macromolecules, which include various monoclonal antibodies targeting specific DNA mutations, and even more recently, the conjugate of a monoclonal antibody tagged to a chemotherapy agent. So this is a group of treatments that are becoming very important in our treatment options for CNS disease. And the reason that is true is happening is because of our understanding of what is referred to as a tumor evolution. And this evolution refers to the genomic changes of the tumor over time. And the drawing on the left shows this initial tumor in blue, which is the trunk. And as time passes, there are subclonal populations within the tumor that develop DNA mutations. And these DNA mutations are what is responsible for resistance to treatment and recurrence. And specific DNA mutations seem to also be drivers and determinants in causing the tumor cell to metastasize to various parts of the body. And we're finding that the DNA mutations in the brain metastasis may be different than DNA mutations in bone metastasis or in the primary tumor. So becoming aware of the DNA mutations offers us opportunities to then target the specific metastasis. So we used to think that it was really the blood-brain barrier that prevented us from treating CNS disease in the setting of systemic therapy. And so now the question is was it really incomplete drug penetration, or is this change in genetic profile really responsible for the lack of benefit of treatment and response from systemic therapy? And as we again understand the genetic differences between the primary tumor and the CNS disease, then we can anticipate improved outcomes by treating these genomic alterations of the CNS disease. And this is an alliance multi-center clinical trial that is now being done. We are a center for this clinical trial, and hopefully we will be able to recruit some patients. The purpose of the trial is to study the genomic changes in CNS disease and compare it to the genomic composition of the primary tumor, and then select a small molecule inhibitor that matches the genomic abnormalities of the brain metastasis. So patients who do have biopsy proven metastatic disease can be enrolled or screened for this clinical trial, and then they are placed in the appropriate treatment arm according to their DNA mutational status using 3 different targeted therapies. I think it's an interesting clinical trial, and this was developed based on this group from Massachusetts that studied over a number of years the difference in the DNA mutations of the primary tumor and the CNS metastasis. And what they found is the upper left on this timeline is the main primary tumor. And over time in this particular patient, 4 different areas of brain metastasis were sampled. And interestingly, the brain DNA mutations were different than the primary tumor. And yet, even though the brain metastasis occurred at different times in the patient's illness, the brain metastasis all had similar DNA compositions. So, I think that the treatment of the specific DNA mutations of CNS disease is really going to result in an improved outcome. The other way we can look for DNA mutations is through a liquid biopsy. We can look at now spinal fluid and perform next generation sequencing on the spinal fluid, just like we can also on the blood. And this is also another way of looking at the genetic profile for CNS disease, leptomeningeal disease, and they're finding that even if patients do not have clinical leptomeningeal disease, but brain mets, we can also see some changes in the spinal fluid, both in looking for circulating tumor cells, as well as circulating tumor DNA when the cells are undergoing apoptosis or ruptured cells. We can find components of the DNA and look for the different mutations. So they're developing, this is through a company called Biocept that we're developing a good working relationship with, and sending the CSF and using these different profiles that they're developing to look for the mutational changes that may be targetable. So this is a list just to help you appreciate some of the options that is now available for treating brain metastasis and leptomeningeal disease using these various systemic therapies. So we now have treatment for non-small cell lung cancer with the different mutations, EGFR or ALK positive, or if they're PD-L1 positive, immunotherapy. Breast cancer is a high area of interest, and this combination under HER2 positive tumors using tucatinib, which is a small molecule inhibitor, trastuzumab, which is a monoclonal antibody for HER2 positive patients, and capecitabine is an oral 5-FU chemotherapy. That combination now has been shown to be beneficial in treating even leptomeningeal disease or asymptomatic or minimal symptomatic brain metastasis, with the hope of delaying local therapy such as SRS or neurosurgical approaches. And the second option under HER2 positive breast cancer is actually one of the macromolecules combining the monoclonal antibody and a chemotherapy agent, and that has become very helpful in managing these patients. Melanoma, we have immunotherapy, and if it's BRAF positive, dual BRAF inhibitors seem to be beneficial. So we have now multiple options with systemic therapy, and it's very targeted, so it's very important we understand the genomic configuration of the CNS disease. And here's an example of how we use this information. This is a 59-year-old woman who presented in 2017 with PR positive disease, but HER2 negative disease, initially with lymph node involvement and bony involvement at the time of diagnosis. She underwent 4 different therapies over the course of 2 years with early recurrence from each therapy. She then developed liver and posterior fossa combined dural metastasis and bulky leptomeningeal disease. Her liver biopsy now showed that she was HER2 positive in the liver, and the CSF liquid biopsy was positive despite a negative cytology, and also showed that the CSF was positive for HER2 mutation. So this is initially HER2 negative breast cancer that became positive, causing or playing a role in her metastatic disease to liver and CNS. She underwent complete craniospinal radiation with proton therapy, tolerated it relatively well. She then underwent the treatment with using the triad that I mentioned, with the chemotherapy, the small molecule inhibitor, and the monoclonal antibody. And despite that, we could see posterior fossa progression. And because her CSF was HER2 positive, the oncologist decided to change the HER2 positive approach and used the monoclonal antibody linked with the chemotherapy combination, brand new, just out. And on the left, you can see her initial presentation. The middle image is her disease status, even after initial therapy for HER2 positive and the complete craniospinal axis radiation. She was not doing well at that point, changed to the new treatment, and is doing remarkably well. Her MRI in the posterior fossa has responded dramatically. So again, I think the role of these new targeted therapies and being aware of these mutations is really going to make a difference. Immunotherapy is playing a large role, but it's also important to recognize the spectrum of neurologic consequences of immunotherapy. And the second case that was presented at Neuropath this morning was extremely interesting in a woman who had breast cancer, and the comment was made that she had immunotherapy. Immunotherapy can cause hypophysitis, and that was in the differential of being an inflammatory cause for what you were seeing clinically. And it turned out she had metastatic breast cancer to the pituitary, which again is increased incidence because of the lack of blood-brain barrier. But it would be interesting to go back and know if she presented acutely after the immunotherapy, in part because of the inflammatory response on the breast cancer and the pituitary, and that caused acute presentation of symptoms. We didn't really discuss that during the case presentation, but it is interesting. Immunotherapy can also cause a demyelinating disorder that looks like MS and can cause pseudoprogression. So again, as we learn to understand the effects of these treatments, we have to take these into consideration in making decisions and interpreting our imaging studies throughout the course of the patient. Radiation necrosis, again, an increased risk with immunotherapy, especially in combination with SRS, and infection, very rare, but PML has been seen. I think one of the greatest challenges as we're learning to use these new treatments and combine them is to interpret the neuroimaging during the management of these patients. And pseudoprogression has become a popular term for worsening of the MRI without evidence of disease progression. And we do know that SRS causes radionecrosis. The peak incidence is between time for at risk is between 6 and 18 months, but certainly may be delayed, especially if then the patient is receiving other treatments such as immunotherapy. We do see pseudoprogression with melanoma. And again, that tends to be an earlier onset within weeks or a few months of treatment with immunotherapy. There's probably an increased risk for pseudoprogression combining SRS and immunotherapy. And also we're finding that targeted therapy may cause pseudoprogression. So again, I think we have to become very aware of the treatment that the patient is receiving when we're interpreting these MRI scans. Our imaging, we usually use a combination of FDG PET studies to help guide us in our interpretation of MR changes, as well as perfusion weighted imaging in assessing the imaging of the patients. This is a patient that did undergo extensive immunotherapy following chemotherapy with non-small cell lung cancer. The set on the left is before the patient started immunotherapy. She had already undergone a craniotomy for recurrence in the right posterior hemisphere, and it was positive for recurrence. She then started immunotherapy, and you can see the worsening of the MRI scan, and each lesion was then operated on at different times. No recurrence was found, and she was then observed, and it took 1 year after she went off immunotherapy for the MRI to improve. So keep in mind, patients with immunotherapy may show enhancement, and we've even tracked the increased enhancement in relationship to the timing of the patient receiving the immunotherapy. And then I just want to end by showing some responses of radiation necrosis to the different treatments that we use for radiation necrosis. This is a patient who developed radiation necrosis from non-small cell lung cancer and SRS. Interestingly, statistically, I mentioned breast cancer prefers the posterior fossa. Lung cancer seems to prefer the parietal occipital region statistically, and melanoma is less consistent, but oftentimes frontal. So this is an example of non-small cell lung cancer with radiation necrosis, and treatment with Avastin improved symptoms, which involved arm and leg weakness and clumsiness. And this is the response to Avastin. Usually it's used in a limited course for about 4 to 8 months, half of the dose of what we use for when we use it for chemotherapy, and again, can be very effective in treating radiation necrosis. This is another case of non-small cell lung cancer, again, same location, but this patient was treated with laser ablation, a very good response following laser ablation. And this is a patient who was treated for a rare lacrimal gland cancer, received head and neck radiation, and about a year later, after treatment, after radiation, developed frontal lobe symptoms. The daughter of this older gentleman said that he stopped texting, he stopped reading, lost interest in eating and socializing, and the MRI showed the development of radiation necrosis. The patient had already had a CSF leak repaired, and I did not think that Avastin was safe. Certainly the neurosurgeons did not want to resect the frontal lobes. And so this patient did receive hyperbaric oxygen therapy and did very well. Within a couple months, the daughter commented that he's back to texting, reading his emails, and now enjoying eating and functioning more normally. So again, hyperbaric oxygen can be effective. Just a few comments on symptom management for the residents. In general, the consensus is to avoid prophylactic anticonvulsants. In the literature, mainly in the neurosurgical literature, there's no evidence that anticonvulsants used prophylactically are beneficial, both perioperative and postoperative. However, if the patient has suffered a seizure, that is an indication for definitely an anticonvulsant. And I think since there's focal pathology, the neurologic recommendations would be certainly to continue that patient on treatment and not have the perioperative approach, but definitely encourage the patient to continue on an anticonvulsant. Usually I discuss with them, if they're going to stop their anticonvulsant, that 20 to 25% of patients with metastatic brain tumors experience seizures at some point during the course of their illness. So the literature mainly looked at the previous use of Dilantin, and oftentimes it was subtherapeutic. They generalized saying that there's no indication for prophylactic anticonvulsants. I think there is a role for judgment in that, but that is the general consensus. And always keep in mind too that these patients are hypercoagulable and at high risk for DVT and PE. Just to close, I just want to make some general comments about the role of neuro-oncology and neurosurgery in the management of these patients. And I think that the medical oncologists, the radiation oncologists, and the other specialists involved in their care really look to us to help manage these patients and explain their neurologic symptoms. So to be an effective oncologic neurosurgeon, I think it's very important that you be aware of the neurologic complications of that patient's cancer and that patient's cancer therapy, be able to form a diagnosis and explain the neurologic presentation, be alert for leptomeningeal disease because that may change your recommendation for neurosurgical approaches, and also be able to identify and diagnose unrelated neurologic disorders to avoid unnecessary surgical procedures and so on. It is a multi-specialty disease, and I can't emphasize enough the importance of the neurosurgeon's role in counseling the family, both in the early presentation of CNS involvement, all the way through the management, and even unfortunately still at the end of the life of the cancer patient with CNS disease. So I think I'll stop there. And any comments or questions?
That was a terrific discussion. Thank you very much for that. Do we have anybody with any questions?
Thanks, Dr. Harris. I just had a quick question about the recent literature on doing neoadjuvant SRS in the setting of brain metastasis before surgical resection. And there's a recent paper in like Lancet, I think, discussing, that as we operate on like these single brain metastases, we're like seeding these patients with leptomeningeal like cells, which is kind of controversial. And now there's a growing body of literature from Mayo that's kind of saying we should do neoadjuvant SRS before we do surgery to prevent leptomeningeal seeding. And I just want to see what you thought about that, I guess.
Yeah, I think, as I mentioned, there are a couple clinical trials. I know that the group from North Carolina, we had met with them once to become part of it. I don't know whatever happened to that effort, but I know there's some in Canada and in the United States looking at that. No, I think that, to be honest, I think it makes a lot of sense, not only for the risk of local seeding or leptomeningeal disease, but also, the risk of radiation necrosis or just removing this treated mass once it's treated with radiation rather than the reverse. No, I think it's a great idea.
I think
Just
yeah.
I'm sorry, just a historical note on that. The first people doing radiosurgery for metastatic disease were the people at the Karolinska with the original gamma knife units in the early 1980s. And they had a significant group of those patients where they thought they had metastatic disease, and they went ahead and treated them with the gamma knife, because otherwise at that time in Sweden, the patients got steroids and went home and got no radiation therapy at all. Radiation oncologists didn't want to treat them. So they would give them treatment with the gamma knife, and then they would take them to the operating room and do a biopsy to prove that what they treated was actually metastatic disease. They did that in quite a number of patients.
I think there's, like Ashish, like you said, there's a growing body of literature. I think Cleveland has published about this as well. The real question is not so much will it help, it's what's the timing, right? Because if you do, a lot of these people are admitting the people the day before, and then you're doing gamma knife, and then the next day you're taking them to surgery. You really haven't given it enough time for it to have a radiobiologic effect of any sort. So I think what we have to figure out really is what's the optimal timing if you're trying to employ that strategy.
Yeah, no, I think that's a great point. And I think it has to become more of a planned approach, because, many of the patients come through by way of radiation, and some, many come through neurosurgery and so on. And I think to really decide on a plan, especially the timing. I think that's a really good point. Would be, definitely a multidisciplinary decision and approach, but I think it's a great idea. Great. Well, thank you. Thank you for listening, and
Thank you, Debbie. That was excellent.
thanks.
Thank you very much.
Mhm.